Hey everyone, this is Dr. Medicine RX, and in today's video we'll be discussing about hidradenitis suppurativa, also known as acne inversa or ectopic acne or Werner's disease. So this is a chronic relapsing inflammatory disease which is characterized by multiple painful inflammatory nodules, abscesses, sinus tract formation and scars in the apocrine gland bearing areas. So this is essentially a disease of the apocrine glands. Coming to epidemiology, the onset is after puberty and between the second and third decade, and it is significantly common in females, and in them the disease was known to remit after menopause. Coming to pathophysiology, follicular occlusion due to hyperkeratosis leading to follicular rupture, following which there is accumulation of cellular debris and cyst and abscess formation, sinus tract formation and later scarring were seen. Coming to associated factors, so genetic factors, because of a family history of HS in about 1/3 of patients, were known to play a role. There was also certain immunological dysfunction in cell-mediated immunity. Hormonal influences were also suspected to play a role because this disease had an onset after puberty with premenstrual flares and improvement in pregnancy, lactation and after menopause in females. And smoking, in smokers there is generally a severe course of the disease because nicotine is inflammatory and also induces epidermal hyperplasia and causes keratinization and conification, and obesity because of increased skin to skin contact leading to microabrasions and also sweat retention in the skin folds, and bacterial infections by Streptococcus viridans, Staphylococcus, anaerobes and gram-negative bacteria were known to play a role because they were found in the cultures taken from the HS lesions. And external factors basically that occlude the follicle, like the mechanical friction, chemical depilators, deodorants and talcum powder were also known to play a role. Coming to clinical features, the onset is insidious and the site is in the apocrine gland areas such as the axillae, groin, perineal and perianal region, the buttocks, infram and intermammary folds. Groin and submammary region, that is the inframammary region, are most commonly affected in females, whereas buttocks and perianal skin are most commonly affected in males. And the typical early lesions, they are solitary, painful, deep-seated nodules, that is they appear like boils, blind boils without any pus directing at the top, and they may persist or resolve at this stage, but most commonly they progress to form an abscess which bursts, yielding pus or serosanguinous discharge, and these lesions they keep recurring and sometimes even at the exact location. So as the primary lesions keep recurring, there is going to be development of sinus tracts with surrounding fibrosis, and draining sinuses have a linear or angular shape and they usually persist as a single sinus, but later on multiple sinuses form and they have permanent discharge. Now, as the disease progresses, there is going to be hypertrophic fibrous scars with indurated plaques, and these plaques they have active inflammatory nodules and sinuses, and multiporous tombstone open comedones are characteristically seen, and they are called tombstone because they appear at the sites of severe inflammation and fibrosis. And the scars that bridge these sinuses are thick, linear, rope-like, and they appear like a bridge, and they are commonly seen in flexural areas. Coming to classification, there are various ways by which we can stage HS, but the most important one is the Hurley staging. So the Hurley staging, it stages HS as recurrent abscesses formation without sinus tracts and cicatrization as stage 1, whereas these recurrent abscesses with sinus tracts and cicatrization as stage 2, and multiple interconnected abscesses, sinus tracts and cicatrization diffusely involving an entire region as stage 3. So coming to investigations, so routine blood tests are necessary, and microbiological examination and histopathological examination are needed for refractory or atypical cases, and imaging with ultrasound and MRI is necessary to know the extension of the lesions. Coming to treatment, general measures is to avoid tight-fitting clothes in order to prevent the occlusion of follicles, using non-narcotic analgesics, cessation of smoking, managing the weight and also stress. Coming to topical therapies, so the first is the antibiotics. Clindamycin is efficacious, cost-effective and safe, and it is commonly used in hidradenitis suppurativa, and its rare side effect is pseudomembranous colitis. Then keratolytics such as resorcinol 15% in a suitable ointment is also effective. Then topical isotretinoin, because it reduces hyperkeratinization and prevents hyperconification of pilosebaceous units, is also effective. And analgesics for symptomatic treatment such as lidocaine ointment, diclofenac sodium gel, and ice packs. Coming to systemic therapies, so the oral antibiotics, we've got tetracyclines in a dosage of 500 mg BD for 3 months in mild and widespread disease as effective. And for more advanced cases, we need combination treatment with clindamycin 300 mg BD and rifampicin 300 mg BD for about a period of 10 weeks. And a combination of rifampicin, moxifloxacin, and metronidazole for 6 weeks was also found to be effective. And ertapenem, which is carbapenem, because of its broad spectrum of activity, bactericidal activity, was also tried. Next, coming to anti-inflammatory agents, single lesions, for single lesions and recalcitrant lesions, and for extensive sinus tracts, we can go for intralesional triamcinolone in a dosage of 5 to 10 mg. And for more severe disease, we will obviously need systemic therapy, and it is in the form of short-term systemic prednisolone, cyclosporin, or for long-term treatment we can go for dapsone, colchicine, and even zinc gluconate. And then retinoids, acitretin 50 mg or more, and rarely isotretinoin may be beneficial in certain cases. And biologics, where adalimumab, which is an anti-TNF alpha drug, is the only FDA approved drug for HS. Other biological agents, infliximab, etanercept, ustekinumab, anakinra, and secukinumab, have also been tried with variable responses. Coming to procedural therapies, so light therapy and lasers, electrosurgery and radiosurgery, and surgical management are what that come under procedural therapies. And surgery is considered after medical control of the disease, or it can be combined with medical therapy. And in this we do radical wide excision followed by healing with secondary intention or graft, because in localized disease this is very effective. However, rarely it can also lead to scarring. Now, other forms of therapy that are available include hormonal therapies, apremilast, botulinum toxin, and external beam radiation therapy.